Good morning, and thank you for joining us for the Health Policy Institute of Ohio's first online seminar, The Path Forward, What Comes Next for Health Policy. My name is Amy Rowley-McGee, and I'm the president of HPIO. With new federal leadership, significant reforms to health and healthcare policy are likely. However, as we have seen in recent weeks, the direction of possible reforms, or that the possible reforms may take, is increasingly unclear. Given that the future of federal health policy changes will undoubtedly impact state health policy and Ohioans, we are hosting this webinar series in order to provide snapshots of federal decision-making throughout 2017. Today, David Jones has joined us to provide the first of these snapshots. Dr. David Jones is an assistant professor of health law, policy, and management at Boston University. His research has examined the political and policy issues surrounding the implementation of federal health policy. He is also working on a book about how states made decisions on whether or not to create health insurance exchanges. Now for some housekeeping. The slides used in today's presentation, as well as a password-protected recording of the seminar, will be posted this afternoon on our website, hpio.net. During the presentation, please feel free to type questions in the question box at any time. There will be time for David to answer questions at the end of the presentation, and we'll get to as many questions as we can. If you don't see the question box, your control panel may be minimized. To bring it back, click the orange arrow in the corner of your screen. And now, here is David.
Hi everybody, can you hear me? Hopefully it works. So first of all, let me begin by thanking Amy, thanking everybody at the Health Policy Institute of Ohio for the chance to be a part of this webinar today. Hopefully the slides will come up. Okay, so very excited. Wish I could be with all of you in Ohio or wherever you are. Just making sure that I have control of the slides. Working out the technology, but I think it's coming. Okay, so for real, thank you, Amy, and thank you everybody at the Health Policy Institute of Ohio. Very excited about this. Couple disclosures to get out of the way. I have no financial interest in anything, nothing to disclose here. My degrees are both in health policy and in political science, so you'll see throughout this discussion today that I'm very interested in the politics of health and how the politics shape the policies that we have. But this is explicitly nonpartisan. I'm just presenting the facts as I see them, and as such I use the terms Obamacare, PPACA, and the ACA interchangeably. So I want to begin with a couple concepts from political science that I think are really helpful for framing the conversation, thinking about how to view what's happening. And one of these concepts is path dependence. It's this idea that, much like the title of this webinar series, The Path Forward, What Comes Next, in order to understand what comes next and where you're going, you have to understand where you've been. That the choices that have been made in the past constrain or shape the choices that are available to you in the future. So because you did A and B in the past, it means options C and D might not be open, but E and F are. So I think that's important. This is just a somewhat self-indulgent photo from my family vacation last summer in the south of France, and I get to think about all the different choices that I had to make when I was on this walk and finding my path forward. Two other concepts. One, I love a book by Frank Thompson, a political scientist, who wrote in 1981 that the criteria for evaluating whether a policy or an implementation is successful is not whether it has solved all the problems, but whether it has left us with a better set of problems than we would have had otherwise. And I think that's a really important lens for thinking about this debate and this conversation about health reform. Does the ACA or does the AHCA solve all the problems? No, I don't think any of these policies will. The question that I think we really need to have in our mind is whether they leave us with a better set of problems than we would otherwise have. And then finally, a quote from Deborah Stone, who said that most of politics is a debate about values masquerading as a debate about facts, numbers, and data, right? So we're going to talk a lot about facts and numbers and data in this conversation this morning, but I think it's worth remembering that at its core, and as most Americans experience this debate, this is a debate about values, the role of government, and lots of other values. So there are three key questions that I'm going to be introducing and trying to work on today. The first is, what problems was the ACA trying to solve? So thinking about where we are coming from. The second is, what is the latest evidence on the ACA's effects? So a really quick introduction to what the ACA is doing. And then finally get into what's coming next and what's happened with the AHCA. So first, what were the problems the ACA, or Obamacare, was created to fix? And it's important to remember that the ACA is a massive law, right? 10 main sections. The Class Act, Title 8, has since been repealed, so there are really kind of 9 sections in effect. But when people think about the ACA, they primarily are talking or thinking about the coverage expansions, which happen in Titles 1 and 2 largely. And that's mostly what I'm going to be talking about today, the expansions of insurance. The state of the world when the ACA was being implemented or first being passed was that 18% of the non-elderly population in the United States was uninsured. And that's really what the ACA was designed to do. Was to focus on reducing the number of people who did not have insurance. And just as a quick refresher, I'm sure most of you know this, but I think it's helpful to get everyone on the same page. There are 3 primary ways the ACA tried to reduce the number of people without insurance. The first is to say that everybody has to have insurance. So if you have an income over 400% of the federal poverty level, then the government says you can afford insurance and you should go out and buy it. If your income is between 100 and 399% of the federal poverty level, the government says you should buy insurance. Maybe it's hard for you to afford. We will subsidize the cost of your insurance on a sliding scale based on income. And then the health insurance exchanges were created so that people could go and shop and compare their plans side by side, much in the way that people buy airline tickets on Travelocity.com. And then finally, if your income is below 139% of the federal poverty level, you now qualify for Medicaid. And that's the Medicaid expansion, which initially was meant for every state, but a Supreme Court ruling in 2012 made this optional for states. And I'll show a map a little bit later showing which states have taken this option. But I think it's really important to show this slide, and I always show this to my students or any group I'm talking to about what the Medicaid expansion is, because I think there's some confusion about what this means. And to understand what the Medicaid expansion did, you have to understand the way Medicaid operated before Obamacare. And that's to say that Medicaid was not the program for all poor people. It was the program for certain categories of poor people. So if your income was below 250% of the federal poverty level and you were a child, you would qualify for Medicaid or CHIP, depending. Some states rolled their children's health insurance program into Medicaid. But if you were a pregnant woman, you had to be poorer than that. You couldn't get Medicaid in most states at 250% of the federal poverty level. If you were a working parent, you had to be even poorer than that. You had to be poorer than the federal poverty level at 63%. If you were a jobless parent, you had to be even poorer. But if you were an adult without children, you did not qualify for Medicaid. So what the Medicaid expansion under the Affordable Care Act does is it gets rid of these categories. And it says that everybody at this income threshold, which here it's listed as 133, but there's a little bit of a buffer built in, so it kind of effectively is 138 or 139. Everyone below that income threshold now qualifies for Medicaid. So fundamentally different way of looking at it. So that's the background, what the ACA is. Now just going to show a couple slides looking at what effect the ACA has been having on insurance coverage. And the top line number that we need to talk about is that the uninsurance rate is lower than it has been for decades, right? The ACA in this way is an unqualified success. It has reduced the number of people who go without insurance. And you can see that there was a pretty steep drop-off between 2013 and 2014, the year that the Medicaid expansion and the health insurance exchange subsidies went into effect, right? So once that went into effect, a lot more people got insurance, and the number of people without insurance decreased. But one of the fundamental political compromises of the ACA is that every state had some flexibility on implementing it differently. And then, as I mentioned earlier, throughout the implementation, the federal government gave even more discretion to states to think about how they would implement the law themselves. So the Medicaid expansion, the essential health benefits, the exchanges, these were all things that states could decide. And as a result, states varied dramatically in terms of how their uninsurance rate changed. You can see at the very top of this graph, Massachusetts, where I am, started with one of the lowest, if not the lowest, rate of insurance, uninsurance in the country, and did not see dramatic changes in the number of people without insurance, but it still saw a change and is still the lowest uninsured rate in the country. And you can see a number of other states. Kentucky saw really dramatic changes, lots more people getting insurance. You can see Ohio, you decreased over the last, that 2-year span between 2013 and 2015 as well. But this is the top half of the country. You can see the bottom of the half of the country. Most of these states rejected the Medicaid expansion. They did not work on creating health insurance exchanges, which didn't mean that people didn't have access to subsidies, but it reduced some of the flexibility that those states had to do outreach to their potential consumers and to advertise and to help people who were trying to get insurance. And so you can see that all of these states also saw decreases in the number of people without insurance, but their starting and ending points are quite a bit worse. So here's a map showing you the 32 states that have adopted the Medicaid expansion and the 19 states that have not so far. Ohio's story is one of my favorites in the country, just from a political science point of view. Very interesting process by which Governor Kasich expanded Medicaid in Ohio. Some other governors have tried to do similar things and in some cases have succeeded. Governor Beshear of Kentucky expanded Medicaid through an executive order, despite not having support from his legislature. But a lot of states remain adamantly opposed, primarily in the Deep South and in the middle of the country. Maine is the lone holdout in New England in the Northeast. And so that results in a pretty dramatic coverage gap, where people who are still in the old Medicaid categories and are poor enough, they qualify for Medicaid on the left side of this, whereas people who are at 100% of the federal poverty level or above, they qualify for help under the marketplaces or the exchanges, but everyone in the middle is in a gap. These people are ironically not poor enough to get help and not well off enough to get help. And so that has resulted in a lot of people in the South, primarily in the really large states of Florida, North Carolina, Texas, going without insurance, who otherwise would have it. Another major effect of the Affordable Care Act is that hospitals have seen dramatic reductions in their uncompensated care. So people who don't have insurance, they delay care, then they show up at the hospital with acute problems, and because they don't have insurance, the hospital more or less has to treat them and then swallows the costs. Under the Medicaid expansion, you can see the red bars. These are different studies looking at the effect on uncompensated care. Between 2013 and 2014, again, when the ACA's major coverage expansions went into effect, the amount of uncompensated care in the Medicaid expansion states decreased pretty dramatically. And even in the non-expansion states, there were decreases as well. So hospitals have found the Medicaid expansion to be something that they have been advocating for very heavily, because it helps insure their population and limits the number of people who show up to their emergency rooms without having insurance. The health insurance exchanges, as I said earlier, a number of states have taken very different approaches. This is a map showing the states in gray as the states that adopted the health insurance exchange. The states in white are the ones that rejected retaining control, and so they gave up control to the federal government. The hashed states, the 6, I believe, states like Iowa and Arkansas and West Virginia, are states that opted for somewhat of a partnership. And then I put these stars in here to show you which states participated in the lawsuit, the 2010 lawsuit that led to the Supreme Court case in 2012, because I think it's very interesting to look at how, in some cases, the politics within a state were very tricky, right? We often think that a particular state has a dynamic, and that's just the way it is. Idaho's very conservative, so of course they sued, but they also did implement the exchange, and their exchange has been quite successful. Meanwhile, in Washington, they really wanted to move forward with the exchange, but they had a conservative attorney general who went ahead with the lawsuit anyway. So there's a lot of politics going on within states here, which is the subject of the book that Amy mentioned at the beginning of this webinar that I am working on that's coming out this year. So other effects of the ACA, one of the things that you hear a lot about in the news is that the premiums under the exchanges went up 25% this past year. And it's important to remember too, when you see that 25% number, this is not referring to all plans for everybody. This isn't talking about people who get their insurance through their employers, which is, you know, the vast majority of people in America. This is talking about people who get their insurance through the exchanges. And so, and again, this is an average, and so it's really important to look within a state how what the changes have been. And you can see within some states there have been some really dramatic changes. But it's important to also think about the change that happens in the amount of tax credits someone receives, right? So the tax credits built into Obamacare fluctuate, and they move with people's incomes, and they are adjusted so that even when somebody has a really dramatic premium increase, the amount of subsidy they receive changes too. And so the actual premium increase most people experienced this past year on the exchanges was around 0% or 1%. But that's not to say that that's sustainable. I mean, that's still, I think, a major issue that needs to be dealt with, that you know, this is not an unlimited amount of money. So it's not, the consumers aren't feeling it, but the government is, and that's something that should be dealt with. Another major issue that needs to be dealt with is that the number of people, the number of insurance companies that are on the exchanges have been decreasing in some ways, in some places over the last year or so. And there are, I think, a variety of reasons for that. It certainly does not look good politically for the exchanges, but you can see this is looking at the total number, and then this graph, this map, looks at county by county, the number of insurance plans, insurance companies that are selling plans in each county's exchanges, right? So you can look and you can see, for example, there are a lot of states in orange where there's only one insurance company that is selling a plan. And so this really defeats the whole logic of the exchange, that this is going to be a place where there's competition and where people could shop, and that this competition would lower the prices. But if there's really only one competitor, then it's not a competition, and there's no reason for them to have lower prices. And so this goes hand in hand, I think, with the issue of the high premiums. And we can talk more about this if there's interest, but my take, and I'm in the process of beginning an evaluation of this, is that in part the criticism that there are so few insurers in a lot of these counties is a bit disingenuous from a lot of Republicans, in particular Republican politicians, because there are a lot of examples of states where when the state was working on creating an exchange and it seemed like they were going to take control of the exchange, such as in Mississippi, that's a state that I've looked closely at, the insurance companies were at the table. They really wanted to be a part of the conversation. They didn't love the Affordable Care Act, but if it was going to happen, they wanted regulation to happen at the state level, and they wanted to be there. They wanted to be part of the conversation. When the politics in Mississippi, for example, changed and the state decided to reject the exchange, the insurance companies left. And they said, if this is going to be run in Washington, it's totally unpredictable to us. Let's just sit this one out, and maybe we'll come in later and we'll be a part of this. But for now, we're going to sit out. And so you had in Mississippi, you would have seen 3, 4, or 5 insurance companies selling plans and exchanges. Instead, you saw in most counties 1, maybe 2. And there are a number of other examples where it worked the other way as well. Another reason we might see this change over time is that there are a lot of companies that have not typically sold plans in the individual market, but saw this as a potential opportunity, and so they thought they would try things out. And they did not do a very good job of pricing, anticipating who their consumers would be and how much they would need to charge to cover their costs and so forth. And so it didn't make sense for them to stay in. Whereas in a lot of cases, the insurance companies that have been in the individual market historically had a better sense of what the market looked like and had a better ability to make projections and to price appropriately. Their plans might have been the more expensive plans initially, but it meant that they were sustainable in the long run, and so they've been able to remain. But we'll talk about this a little bit more in a minute, but I think this coming year will be very important, both for the policy and for the politics of the exchanges in Obamacare, and seeing how many insurers decide to offer plans next year. Of course, one of the important challenges is that just because you have insurance, and even if you can afford the premium, doesn't mean you can afford the deductible. And so there's been an increase in plans on the exchanges that have higher deductibles. And so there was one analysis that showed that 90% of enrollees in the ACA marketplace plans qualify as having a high deductible health plan. And that's something that I think is very concerning for a lot of people, that whether their coverage is really increasing access. Okay, so with that context, and there's a lot more that could be said about all of that, it's now, I think, time to turn to what's happening now and what comes next. And I'll say that this has been enormously valuable for me to reflect on everything that's happened in the last 3 months since the inauguration. But it's worth mentioning that this is a very different conversation than we expected we would be having, right? So I wrote a paper last fall that was published in an academic journal looking at the health reform platforms of Hillary Clinton and of Donald Trump. But I'll be completely honest, I really did not expect Donald Trump would win. And so on November 9th, I had to dig up that paper and look at it and say, okay, what did Donald Trump say he was going to do about health reform? Again, what is this going to mean for the ACA? And so I wrote a blog post on publichealthpost.org, which was just a list of 20 questions, not even attempting to answer, but just trying to make sense of what does the election of Donald Trump mean for Obamacare, for health reform, for the debate about health reform. And if I could pause here and just shamelessly plug, publichealthpost.org is a website housed at Boston University that I run with a fantastic team here, where we put out one story a day on a public health issue that we care about and that we think others should be paying attention to as well. And sometimes we're translating research, other times we're highlighting cool graphs, sometimes we're profiling interesting people. And so we'd love it if you went to our homepage, publichealthpost.org, or followed us on Twitter or Facebook, and you can see the icons at the top of every page on publichealthpost.org. So now, 3 months after Donald Trump was inaugurated president, we're starting to get some of the answers to the questions that I posed on November 9th. And so today actually preparing the presentation today has been enormously helpful for me to think about just how much has happened in the last 3 months. Really kind of an overwhelming amount has happened in the last 3 months. So I'm going to walk you through the timeline a little bit so we can appreciate just what has happened, the terms of the debate along the way, and I think this will give some context for what could happen next. So the first decision that the Republicans, Paul Ryan, Mitch McConnell, Donald Trump, and all of their colleagues had to make, in effect, was what kind of bill do we pass? Do we take the bill that Congress had already passed in December 2015, and we just pass that again? And this bill was effectively a repeal and delay. It was a law that says the ACA is repealed, and it will be in a couple years. And we don't know yet what's going to replace it, but we are going to work on that. We'll figure it out in the meantime. And of course, the only reason that did not become law when Congress passed it in December 2015 is because President Obama vetoed it. And so there were a number of Republicans who just assumed once Congress started up again in January of this year, once Donald Trump was inaugurated, let's just pass that same law, and now we have an ally in the White House. It would become law, and we could repeal the ACA. And the advantage of this is it puts pressure on Democrats to cooperate, because then it says the ACA has already been repealed. There's nothing that you Democrats can do about it, and so you might as well work with us to, in your eyes, mitigate the damage that this would do. Of course, it's very different to pass a law when there's no chance it would be enacted than to pass the law when it would be enacted, right? It's very different to make a threat when there's no chance you'll have to follow through on that threat and be held accountable for the consequences. January 2017 looked different than January 2017 looked different than December 2015 because Republicans heard a lot of feedback from their constituents that it wasn't going to be acceptable just to repeal the ACA, take away insurance coverage without a plan of what comes next. And enough Republican politicians were not willing to go down that road. And so there was a procedural vote that made this clear in January, where the Republicans, particularly in the Senate, just didn't have enough votes to move forward on a bill without a replacement. So then the question is, do you go for a major comprehensive replacement? You try to do everything, or do you go for something a little bit more incremental, something a little bit more scaled back? And the procedural question, or the procedural limitation, is that Republicans only have 52 seats in the Senate. Up until yesterday, in most cases, you needed 60 votes to get anything through the Senate. But there was this sort of loophole, the reconciliation process, that allows senators to pass legislation as long as it has to do with the budget with just a straight majority. Bill Clinton tried to do this in 1993, but Senate parliamentarians rejected that. Democrats did successfully use this process to get the ACA passed in 2010, even though they had 59 seats, not 60 seats in the Senate. And so Republicans have decided this is the path they're going to use to get a bill through the Senate, even though they only have 52 seats. Of course, they still have a very thin margin that they have to hold to get a straight majority of 51, but this at least gives them the ability to pass something in the Senate. It does limit, however, the types of policies that can be included. They can't just do everything they want to do. They have to do things that will pass muster in terms of being about the budget. And so then the question really is, replace it with what? What do you replace the ACA with? And I've written on Public Health Post and a few other places that, to me, the Republican Party right now feels more like the Democrats in 1993 than the Democrats in 2009. And what I mean by that is, in both of those instances, Democrats came into power controlling the White House for the first time in a little while, and controlling Congress with pretty decent majorities, feeling like this is our time, this is our chance to get some major health reform through. But in 1993, there was no consensus on what that would actually mean. Everybody, wanted everything from single payer on one hand to more managed competition on the other. Whereas in 2009, the leadership in both the House and the Senate really made it clear, we're going to get something through. We're going to work together. options like single payer are not on the table, and they got something through. So right now, Republicans have consensus that they want to pass something. They just don't have consensus on what they want to pass. Even so, it felt like there was momentum building towards a path towards passing a law until late January. When the Republicans held a retreat in Philadelphia, which was meant to be this galvanizing moment where they emerged from this with a grand compromise, but instead it really made it clear how far apart they were. You may remember that somebody pretended to be the wife of a member of Congress, snuck into the retreat and recorded conversations where the members of Congress were just really upfront about how little consensus they had and how they had no idea what they were going to pass, and we better be careful what we pass because we're going to own health reform after this. And a number of members of Congress heard similar things when they went out into their districts. I was particularly intrigued by this town hall from Jason Chaffetz, which was largely about his role in the House Oversight Committee, people criticizing him for not doing enough oversight on President Trump and Russia. But there was a lot of anger there as well about health reform and people afraid that they would lose coverage. And in some ways, you started hearing for the first time about people who say that their lives had been saved by the ACA, or that they had access to care that they never otherwise could have had because of the ACA. But Republicans, in part because of the tense politics that were brewing throughout the month of February, they worked in secret to create a plan. And one day it leaked that the outline of the plan, or maybe even the bill itself, was locked up in some office in the basement of the Capitol building. So a number of members of Congress, including Senator Rand Paul, tried to track down this legislation, and then finally, when they got to the room that the law was supposed to be locked inside, tried to get in, but staff and security guards were outside blocking entrance to that room. Rand Paul even brought his own copy machine from his office so that if he somehow did get access to the law, he could make photocopies and share it, with the idea being that if we're going to have a major health reform debate, it needs to be out in the open and it needs to be transparent. So that was March 2nd. The law was finally introduced on March 6th. Paul Ryan, with some House leadership colleagues, held this press conference, and the American Health Care Act was released. And so, taking a minute, 2 slides worth of information about what's in the law, it would have eliminated the individual mandate. It keeps the pre-existing condition requirement, but says that insurers can add a 30% surcharge for anyone who has been without coverage for 63 days. They're massive tax cuts, which primarily benefit people with incomes over $200,000. The law says that states could keep the Medicaid expansion, but that the federal government wouldn't pay for new enrollees. So effectively phasing out the Medicaid expansion, because as people move off of Medicaid, they could never come back on. So the number of people there would go down dramatically. There was also a pretty dramatic restructuring in how Medicaid would be financed. So instead of being more of a blank check from the federal government with the FMAP percentage that every state gets, there would be a per capita cap, saying that states would get a certain amount of money based on the number of people signed up. There would be greater investment in high-risk pools, more or less acknowledging that some people would lose coverage because of these changes, and so the high-risk pools would be one way to deal with that. There was a change in the ratio that old people could be charged relative to young people. So the idea here is that in order to get more young people onto the exchanges, you need to make their care more affordable. And to do that, you need to be allowed to charge old people more. And so the advantage, of course, then if you get more young people into the risk pool, then you have a more balanced pool, and it can be more balanced and affordable. One really interesting component of the American Health Care Act is that it kept the basic framework of Obamacare in terms of using tax credits to help people afford insurance, which in some ways is not surprising. Even though Republicans have criticized this dramatically over the last 7 years, this was the plan that George Bush Sr. proposed as the alternative to what Bill Clinton was campaigning on in 1992. And this is what Paul Ryan effectively said he wanted to do in his alternative to the ACA. I believe Richard Nixon, his plan in the early 70s to reform healthcare in America had something like tax credits to help people. But what is dramatically different in this case is that the tax credit would be based on age, not on income. So it's not designed to help people who are poor, it's designed to help people who are older, with the idea being that older people have more expensive care, and so they need a little bit more money. Of course, Bill Gates doesn't need as much help as the woman down the street from where I am now, which is a relatively poor neighborhood, but they would both receive the same amount. So there's, I think, an important issue there. And then also health savings accounts would be prioritized and supported. So that was March 6th, and the bills were rushed pretty quickly to two major House committees, the Energy and Commerce Committee and the Ways and Means Committee, with markup hearings, I think, if I remember correctly, happening on the same exact days. So really at the same time, really making it difficult for opponents or even allies, frankly, to be on the same page and to really study the law, really trying to push this through quickly. And like I said, the committees passed the legislation very quickly the next day along party lines. And this was done before the Congressional Budget Office had even completed analysis. So you may remember that Republicans, when the Democrats were passing the Affordable Care Act, Republicans criticized them for rushing a bill in the middle of the night, something that nobody had read, and something that we didn't have enough information on. And there, potentially valid, there's some validity to some of that. But of course, the ACA was passed in March of 2010, so there was 14 months worth of debate. And the committees took many months with a lot of public hearings and reports from the Congressional Budget Office. So this is really kind of everything that the Republicans criticized the Democrats for, but kind of even a more extreme version of this. Paul Ryan held a PowerPoint presentation on March 9th. There was some sense that the messaging around the HCA wasn't working, and so he thought this might be some way to solidify his nerdiness chops and get out there and try to sell it and frame it for the media and for the public. And I don't think it particularly worked, particularly because in the next few days the report from the Congressional Budget Office did come out, and it was a pretty hard report for the AHCA. And interestingly, Donald Trump and other Republicans tried to discredit this report and say that this is false numbers, but there are people who have leaked the White House's internal estimates and show that this was actually pretty close, maybe even slightly better than what the White House estimated the law would do. So the most important numbers from the CBO report were that the new law would reduce federal deficits by $337 billion over 10 years, which, for the most part, I think was a good thing. But of course, it would do it by dramatically reducing taxes for people who are over $200,000 and then dramatically cutting benefits to people who are poor, right? So some people have called this one of the most dramatic redistributions from the poor to the wealthy that we would have experienced in U.S. domestic policy. The CBO reported that 14 million people would lose insurance in 2018, so almost immediately, and that in 10 years, the number of people who would lose insurance relative to what would have happened would be 24 million people. So a lot of people losing insurance, bringing the total number of people without insurance up to 52 million. The CBO reported that premiums would increase 15 to 20% higher than under the current law. There would be a 10% on average decrease in 10 years from now, but it's important to remember that this is because all the poor people who are unhealthy would not have coverage anymore. So you take them out of the risk pool and premiums go down for most people. And so one of the examples that got talked a lot about in the media was a 64-year-old woman with an income of, let's say, $26,000 a year. Under the ACA with the tax credits, she would receive $1,700. Her premium would be $1,700 a year. Under the AHCA, her premium would be $14,000, right? So a dramatic difference, and that did not play well across the country. Nonetheless, within a matter of days, the House Budget Committee passed a bill, this time though not along party lines, with 3 Republicans from the House Freedom Caucus voting no. And we saw public opinion changing, that you know, for one of the first times in the last 7 years, you can see the blue line here, the percentage of people who feel favorably towards the ACA went up and was higher than unfavorable. That number has, in the new poll that just came out a couple days ago, has dropped back down, and those two numbers are about equal. But the ACA was becoming more popular, and only 17% of Americans liked the the American Health Care Act, the Paul Ryan plan. And so we ended up seeing this really dramatic power struggle between the very conservative House Freedom Caucus and Paul Ryan and Donald Trump. And finally, Donald Trump issued an ultimatum saying, Friday, March 24th, that's the final date. We're going to vote on it, take it or leave it. And in the end, they tried to negotiate, and this is kind of now a picture that's become infamous. All the people negotiating to take away the essential health benefits, which would have dramatically reduced maternity coverage and other coverage for women. Of course, there's not a single woman in the room. But a deal was not struck at that meeting, and the House Freedom Caucus decided they would not support the bill, in part because a new projection that came out after some of these negotiations showed that the new bill would actually save less money but still result in the same number of people losing coverage. So it was really hard to explain that back home. And then on March 24th, the AHCA died. So I have a couple slides to wrap this up and thinking about what comes next. And I'll say this is a really disorienting time to try to follow health reform, because every day I feel like I read stories that says there's no compromise, things are dead. And then later that same day I read about this major new compromise that's just happened, and this idea that's coming out. Now Congress is going into recess, and so people, there's going to be less activity over the next few weeks in Congress, but people are going to be back home trying to explain to everybody what's happening. And there are proposals out there largely based around giving states more flexibility, saying if you like the ACA, you can keep some of the provisions, but if you don't like the ACA, you can get rid of the expansion, you can get rid of the essential health benefits, you can get rid of the community rating, so you can allow your insurance companies to charge sick people dramatically more. And I think this is actually part of the Trump administration's strategy of collapse and replace, right? So no longer just delay and replace or repeal and replace. Donald Trump has made it clear he believes that the Affordable Care Act is a failed law and will collapse, of course. And then when it does, then there will be pressure on Democrats to come to the table and cooperate and get a law through. Of course, Donald Trump is in a powerful position, along with Tom Price and others at HHS, to proactively undermine the Affordable Care Act. So we'll see on June 21st, that's the deadline that insurance companies have to file plans for the next year. We'll see how many plans, how many insurance companies are going to remain. What I'm hearing so far is that there's so much uncertainty about whether the Trump administration is going to do things like enforce the individual mandate, whether they're going to really advertise heavily for the marketplaces or not, whether they're going to do other things. There's so much uncertainty that insurance companies are feeling like it might not be safe to be in the exchange, right? So in some ways, this strategy of making it seem like there's compromises and then they die, and constantly talking about potential changes has the effect of scaring off insurance companies. And so whether these compromises happen or not is still potentially part of the strategy for the Trump administration. And the calculus here, political calculus, is that Democrats and President Obama will be blamed when the ACA fails. But a very interesting new poll came out this week from the Kaiser Family Foundation showing that 61% of people feel that Donald Trump and the Republicans are in control of government, and therefore they are responsible for the problems that happen with health reform, not Obama any longer, right? The Republicans have control of Congress and the White House. If there are problems, it's their fault. But you can see there's a dramatic shift in terms of party, where Republicans are still very confident that Trump will deliver and get something through, whereas independents less so, and the Democrats really not confident that Congress can do anything. There's a major lawsuit that's been happening where the House of Representatives sued the Obama administration over the appropriation of cost-sharing subsidies, or the spending of cost-sharing subsidies, even though Congress had not appropriated any money for that. But now Donald Trump is in the White House, not Barack Obama, and so he could just stop defending this lawsuit, which would mean the House would win and insurance companies would stop getting access to these subsidies, and people would stop losing money to help with their copays and their deductibles. So that's going to be a really important issue on the horizon. States are going to be enormously important going forward. We saw already Kansas has tried to pass Medicaid expansion. The legislature passed a bill that Governor Brownback vetoed, but I would not be surprised if a number of these 19 states that have so far rejected Medicaid now come to the table and they pass a law, and then they ask for a waiver from the Trump administration to do a lot of the things that conservatives have been trying to do for a number of years, such as getting work requirements or other elements into their Medicaid programs. So there are lots of other issues happening at the same time. The Gorsuch nomination, it's going through the Senate this week. How does the change of the nuclear option, the filibuster there, does that filter out to other issues? If so, then Republicans could potentially go after more things. There's some other major deadlines happening with the federal budget. We've already passed a major deadline for the debt ceiling, which puts us in a situation where the federal government will default by October or November. So there's going to be a lot of pressure for some kind of deal there. Meanwhile, the deadline for CHIP funding ends September 30th, so there's going to have to be some kind of deal there, or the CHIP program will have problems. So this is my last slide. Again, bring it back to what I said at the beginning, that when we're thinking about whether any of these policies are good or not, the right criteria is not whether they would solve all our problems, but whether they would leave us with a better set of problems than we had before. And again, most of politics, even though we've talked mostly about facts, numbers, and data this morning, this is really a debate for most people about values. And so with that, I say thank you, and I'm really enjoyed this conversation, and I look forward to taking any questions.
Great, thank you, David. We do have a couple of questions. The first is, what does an ACA collapse look like? In other words, what are the signs that it is collapsing or has collapsed?
Yeah, it's a great question. I mean, so I think, there's no way in my mind that the ACA collapsed this year, right? So just because bad things happened this year doesn't mean that the ACA is definitely in this so-called death spiral. But I think if we see large numbers of insurance companies pulling out, and if we see premiums skyrocketing and lots of people dropping out and no longer signing up, that would be a sign that there's trouble. But again, I think one of the real interesting challenges that we're going to have going forward is that a lot of the data that we're going to have about this is going to be coming from the Trump administration themselves. And you know, my personal politics aside, it really worried me that we had such a debate about the crowd sizes at the inauguration when we could objectively see one picture against another on our screen, right? And there was no way to deny that one picture had more people than another one. When it comes to a lot of the data that we're going to get about how many people have signed up and what the premiums are and so forth, we're really only going to, you know, we're not going to be able to see both pictures at the same time. We're really just going to be getting what the Trump administration is putting out. And that's true of every administration, but I think there are reasons to be worried about the spin of data from this administration.
Right, do you have any information on the conversations that happened just this past week between and among Republicans, Democrats, and the White House? What were the I guess main topics of conversation that were perhaps going to culminate in something this week?
Yeah, and so first of all, I don't think there was ever any chance that anything was going to happen this week. I mean, there was supposedly was going to be a bill that was going to be rushed to the floor yesterday and get voted on, and then that didn't happen. So I think it's really it's a show in part. I mean, I think they're really trying to get some compromises through. But one of the things that gets talked a lot about is the essential health benefits. That was one of the compromises that the Trump administration tried to make to win over the House Freedom Caucus by saying, you can get rid of the essential health benefits that were in the ACA for the exchange plans. But now some of the House Freedom Caucus have come back and said, we actually don't really care about that so much. I mean, that's not what we're, so that kind of remains to be seen. State flexibility is, I think, as I said, one of the real big things that if there is a compromise to come out of all this, it will probably involve a lot of discretion for the states. That's how the ACA was passed in the first place. I mean, there was, debate about whether there should be a national exchange or state exchange, things like that. And one of the kind of pressure release valves in American politics is that when Congress can't figure out what to do, it just punts it down to the states, which is great for Congress, but then it means that states have a lot of pressure to do things, but then they don't have the money often to do it. So, yeah, I mean, and I think block grants, and that's something that gets talked about a lot, is something that a lot of conservatives want. But the challenge, of course, is everything you do to win over the conservatives, you lose moderates, and so it's really unclear whether there is a needle to be thread here.
So do you, in your opinion, do you think that there's any potential for bipartisan cooperation? Is there any set of circumstances under which the Democrats might join with moderate Republicans to craft something?
Yeah, it's really, I mean, I think there's always a possibility, but it's really hard for me to imagine what that would look like. Democrats just feel like there are 7 years worth of burnt bridges here. The ACA, when they tried to pass, they tried to get a bill through the Senate Finance Committee that they thought was a conservative compromise, and Republicans just refused to cooperate. And I think the dynamic has really remained. So I think it's going to be very hard for Democrats to want to compromise. And a lot of people are actually saying that there is a bipartisan compromise out there, and we passed it 7 years ago. The ACA is the bipartisan compromise. It contains a lot of Republican ideas combined with some liberal ideas. But I think what we're seeing now with the Gorsuch nomination and lots of other things, just it makes it really hard for me to believe that there's going to be some terms in which Democrats and Republicans work together on an issue as polarized as health reform.
What issues would you look for resolution, if any, before June 21st, or to be resolved, if any, before June 21st in helping the insurers to make their plan filing decisions?
Yeah, that's a great question. I think it really depends on the state, and it depends on the insurer's experience, so it's hard to make a blanket statement about that. But if I were an insurance company, I would really just be hoping for some kind of stability from the Trump administration, some sense that, like, we know what to expect, we know what this enrollment period is going to look like, and we know that this is going to be supported. Which reminds me, actually, one of the things that I've heard on the table being talked about is insurance companies want a shorter enrollment period, and they want to reduce the number of special enrollment periods so that people, in some ways, to reduce the adverse selection problem, that people, you know, only are signing up if they have some special event, which then means their care is going to be very expensive. But yeah, I think it's very hard for insurance companies and frankly all stakeholders at this point to really know how to approach the next year. And I think, you know, even if the Trump administration and the Paul Ryan Congress were able to get something through, I think there's a lot of concern from stakeholders that it would be undone in 3.5 years from now by a new Democratic president with a new Democratic Congress. And so, you know, there's just a lot of uncertainty and instability, which is something that no organization likes when they're trying to make projections.
Well, I want to just provide a brief point of context before we get to our last question. And that is, here in Ohio, a much larger number of people have obtained coverage because of the new Medicaid eligibility levels. It's well over 700,000 Ohioans have gotten coverage through that route, as compared to a little over 200,000 who have purchased insurance through the marketplace. So I think, of course, for those over 200,000 people, that coverage has been very important. But looking at the scale, I think paying close attention to what happens in Medicaid because of the size of the potential impact is important.
Absolutely.
So let me just get to our last question, and that is, what is your prediction or best guess for where things will stand a year from now? Regarding to the status of the ACA or any other potential legislation that might emerge?
Yeah, so it's funny, I did a couple TV appearances recently where, looking back, I realized the host was trying to end on an optimistic note, but there was just nothing like it. That was the question that stumped me the most, because I couldn't see what to be optimistic about in terms of health reform politics. I mean, I think in a year from now, we're going to be at a pretty similar place as we are now. I think for a while it seemed inevitable that Republicans would pass something, but I think now, if I had to place a bet, I would say the Republicans don't pass something on health reform. So I think there's that. And I also think that in terms of the politics, there are a lot of liberals who are hoping that Republicans pay a price for this, how this is played out. And there might be some individual Republicans who pay a price. I think Paul Ryan's credibility has paid a price, but Democrats need a real strong reality check in terms of thinking about whether they're going to be able to win back the Senate or win back the House. The map is just so unfavorable for Democrats. So I mean, I think we'll be in a pretty similar place we are now. So I think the Medicaid expansion will still be there, and you know, we'll still be talking. But I'd be surprised if it's too different than now.
We here at HPIO have given up on making predictions. In fact, one of our staff says that she just takes whatever she thinks is going to happen and then picks the opposite.
That's right. It's the George Costanza approach. Exactly.
Yes. So that's all the time we have. Thank you, David, for your time and your insight. Remember that the slides used in today's presentation, as well as a password-protected recording of the seminar, will soon be available on our website, hpio.net. The next seminar in the series will feature Bob Lashevsky, who is the president of Health Policy and Strategy Associates Incorporated. We hope that you can join us for that presentation via webinar on July 14th. Who knows where we'll be at that point? I'm sure there will be more news to report and more predictions to be made. Thank you again, David, and hope that you all have a great weekend.
Thank you, Amy. Thank you, everybody.